Hello everyone, welcome to Medicuisine. Today we are going to discuss about Parkinsonism. This is our third video from the neurology section. So Parkinsonism is a clinical syndrome characterized by these four symptoms: akinesia, rigidity, tremor along with postural instability. Akinesia, rigidity, tremor along with postural instability. Now, in the previous lecture of Huntington disease, we have discussed that Huntington disease is primarily a movement disorder. Parkinsonism is also a kind of movement disorder where there is akinesia or bradykinesia. Now, Parkinsonism and this term, idiopathic Parkinson disease, which we have highlighted, these are two different entities which need to be addressed. Parkinsonism is simply a combination of these four symptoms, and Parkinsonism may be caused by many different things. Like we have written this, causes of Parkinsonism. The most common cause is idiopathic Parkinson disease, which is simply called as Parkinson disease. So Parkinson disease is a cause of Parkinsonism, and 80% of cases of Parkinsonism, they are actually caused by idiopathic Parkinson disease. Besides Parkinson disease, there are other causes of Parkinsonism as well, like the atypical antipsychotics, the metoclopramide and prochlorperazine, the tetrabenazine, which we have discussed in Huntington disease, which actually depletes the excitatory neurotransmitters in the brain. So relieving the choreiform type of movements, which is the hallmark of Huntington disease. The sodium valproate is also known to cause Parkinsonism. The sodium, manganese and MPTP, these three things are also known to cause Parkinsonism. So along with these drugs and toxins and idiopathic Parkinson disease, there are neurodegenerative diseases like Alzheimer's disease, Lewy body dementia, the multiple system atrophy, the corticobasal degeneration, and genetic diseases like Huntington disease, like Fragile X syndrome. They are also known to cause Parkinsonism. What I mean is, Parkinsonism and idiopathic Parkinson disease are two different entities. The Parkinson disease is a cause of Parkinsonism. Actually, the 80% of cases of Parkinsonism, they are caused by idiopathic Parkinson disease. Parkinson disease is a whole different world. Besides these symptoms, which are the hallmark symptoms of Parkinson disease, besides these symptoms, there are many different abnormalities. So Parkinson disease is a whole different story. It is a progressive disease actually. So the idiopathic Parkinson disease is actually our today's topic. So first question arises, why it is called idiopathic? Because there is no direct cause known to cause this Parkinson disease. There are risk factors which actually contribute to the development of this disease, but there is no direct cause known. So that's why it is called idiopathic. Among risk factors, age is considered as a risk factor, and genetic factors are also recognized to contribute to the development of Parkinson disease. Although this Parkinson disease is the disease of elderly, most of the patients of Parkinson disease you will see will be beyond 70 and 80, and only 5% of Parkinson disease patients, they are below 40. So the average age of onset for Parkinson disease is 60 years. 60 years. So what is the pathophysiology of Parkinson disease? Just like we discussed in Huntington disease, where there was degeneration of GABAergic neurons in the caudate nucleus, Parkinson's disease is also a kind of degenerative disease where there is degeneration of dopaminergic neurons and the substantia nigra pars compacta of the basal ganglia. So the nigrostriatal pathway is degenerated in the brain. With the degeneration of this nigrostriatal pathway, there is depletion of the neurotransmitter dopamine in the brain, which causes the movements to be slowed down, called as bradykinesia. So the pathophysiology is somewhat like this. Along with the degeneration of dopaminergic neurons, there are alpha-synuclein inclusions in the nigral cells, which are called Lewy bodies. So, Lewy bodies is also an important histological feature of the Parkinson's disease. And these Lewy bodies are made of alpha-synuclein inclusions. Now, alpha-synucleinopathy is another concept. Alpha-synucleinopathy is a disease where the alpha-synuclein protein is known to cause its role in the pathophysiology of the disease. So, up till now, 3 diseases are known for which the alpha-synuclein is known to cause its role in the pathophysiology of these diseases. One is the Parkinson's disease. Along with Parkinson's disease, there is multiple system atrophy and Lewy body dementia. So Parkinson's disease, Lewy body dementia, and multiple system atrophy are the 3 diseases in which the alpha-synuclein is known to play its part, to play a role in the pathophysiology of the disease. So these together are called alpha-synucleinopathies. Now we are into the clinical features of Parkinson's disease. The typical presentation of Parkinson's disease is with motor symptoms. The motor symptoms like bradykinesia, like tremor, rigidity, postural instability. These are the motor symptoms with which the Parkinson's disease presents. However, these motor symptoms may be preceded by non-motor symptoms for many years before the diagnosis of Parkinson's disease is made. These non-motor symptoms include hyposmia, which is actually the reduction in the sense of smell. The anxiety or depression may be there for many years before diagnosis of Parkinson's disease is made. And constipation, REM sleep behavior disturbance. So these are the non-motor symptoms which may precede the typical motor symptoms of Parkinson's disease, which are 4 in number: bradykinesia, tremor, rigidity, postural instability. So in clinical features, we will describe these typical symptoms, the typical motor symptoms of Parkinson's disease. The hallmark motor symptom of Parkinson's disease is bradykinesia. Remember, the hallmark motor symptom of Parkinson's disease is bradykinesia, which is actually the slowness of movements. Question arises, how will you check for bradykinesia in a patient who you suspect for having Parkinson's disease? You will ask the patient to do a repetitive movement, like you ask for the patient to do like this. So these repetitive movements will become shorter and shorter with time, like this. You will ask the patient to do this, and it will come out to be like this. So this fatigability, this slowness of movements, this is called bradykinesia. So bradykinesia, which I think is the most disabling, which is the most fearsome, which is the most debilitating symptom of the early disease, because it actually affect the routine activities of the patient, like tying shoelaces, buttoning clothes, and even rolling over in bed at night becomes very difficult for the patient due to this bradykinesia. The bradykinesia affects the handwriting of the patient. The handwriting becomes very, very small letters. The patient tends to write very small letters, so which is called micrographia. Like, you ask the patient to write Medicuisine, instead of writing like this, which is normal, he will write Medicuisine like this. So micrographia is also a feature of Parkinson's disease, which is actually due to bradykinesia. And also hypomimia. Hypomimia means expressionless face, which is also due to bradykinesia, because the movements of facial muscles, the movements of facial muscles is disturbed due to bradykinesia, which causes expressionless face. Now we said that the bradykinesia is the most disabling symptom of early disease, because as the Parkinson's disease progresses in very later stages of the disease, it is actually the dementia that causes very difficulty for the patient. So in the early disease there is no dementia, so the most disabling symptom would be bradykinesia for the patient. The most concerning symptom of Parkinson's disease and early disease, this will be bradykinesia actually. So moving on to the second clinical feature, which is tremor. Tremor is an early symptom but present in about 80% of patients. So in 20% of patients, the tremor may be absent. But in many patients, the tremor will be the dominant symptom for many years. So the typical tremor will be like the unilateral wrist tremor. Actually, the clinical features like bradykinesia, tremor, rigidity, they tend to be asymmetrical in the early disease, and as the disease progresses, they become symmetrical. So tremor is also unilateral first, affecting limbs, and it can also affect jaw, chin, but cannot affect the head. So the classical tremor which is associated with Parkinson's disease is this pill rolling tremor. The patient is when the patient presents to you, his hand or her hand is like he's doing like this. He's doing like this with the fingers. So as he is rolling a pill in between these fingers. So this pill rolling tremor, which is actually a resting tremor, unilateral, affecting the limbs. This is the typical tremor for Parkinson's disease. And remember, the tremor associated with Parkinson's disease is a low frequency tremor, 4 to 5 hertz only. Moving on to the third clinical feature of Parkinson's disease, which is rigidity. And rigidity is specifically of cogwheel type, and it affects the limbs. It also affects the posture of the patient, and the posture become flexed or stooped type. The normal patient, which is like this from the back, which looks like this from the back. This is the back of the head, this is the back of the trunk, and these are the legs. It becomes like this, like kyphosis. So the posture is affected, which becomes flexed, which becomes stooped posture due to this rigidity. And the postural instability, which is another clinical feature of Parkinson's disease, because the postural writing reflexes are impaired, and this occurs early in the disease, but fall doesn't occur until late in the disease when freezing develops. Now later in this video we will see that when a patient of Parkinson's disease tries to move, it is very hard for the patient to start the movement, or any movement. When the patient performs any movement, it is very hard to start the movement, and also it is very hard to stop the movement. So sometimes it becomes very hard for the patient to start a movement, to start, like when you ask the patient to take few steps, it is very hard for the patient to start this movement. So sometimes it becomes very difficult, and it seems that the patient is freezed. So when this freezing develops and the patient is freezed, and when the patient tries to start the movement, there is high probability that the patient would fall. So the falls actually they are very common in late stages of the disease when freezing develops. In early disease, there is postural instability, but the risk of fall that is not like there exists in later stages of the disease. Now, the dementia occurs late in the disease, which is the most likely to impair the quality of life in later stages. So in late stages of the disease, it is the dementia which is the most concerning thing for the patient and also for the caregivers. And in early stages, the most concerning feature is bradykinesia. Now we have discussed about the clinical features of Parkinson's disease. Now let's talk about investigations and diagnosis of Parkinson's disease. Remember, the diagnosis of Parkinson's disease is clinical. You don't need any investigation to establish diagnosis of Parkinson's disease. You can clinically diagnose the patient. You can diagnose the patient from clinical features alone. The CT, MRI, they are usually normal. And the PET scan, which is the positron emission tomography scan, is abnormal even in the early disease. But remember, for establishing diagnosis, you don't need any investigation. You simply diagnose the patient from the clinical features. Now, always exclude Wilson disease in patients of age less than 50 presenting with movement disorders. Wilson disease, which is a genetic disease where there is defective metabolism of the copper, due to which copper starts to deposits in the central nervous system, and it manifests in different types of movement abnormalities. So a patient which is less than 50 presenting with movement disorder, you should exclude Wilson disease. Time for some fun questions. Question number 1. How will you differentiate essential tremor from Parkinson's disease? Essential tremor from Parkinson's disease. So the answer is, in Parkinson's disease, there is other neurological features also. Along with tremor, there are like bradykinesia, there is rigidity, there are postural changes, there is gait disturbance. So along with tremor, there are other neurological features as well, which will differentiate essential tremor from Parkinson's disease. But sometimes the tremor, this is the only dominant feature of Parkinson's disease for many years. And in those cases, you will see that in a patient who is having essential tremor will have positive family history. So a positive family history, and the essential tremor will ameliorate with alcohol. So amelioration with alcohol and positive family history, these features can also differentiate essential tremor from Parkinson's disease. A positive family history, and amelioration of tremor with alcohol. Amelioration of tremor with alcohol. Essential tremor usually ameliorates with taking alcohol. So positive family history and amelioration with alcohol. These two features differentiate essential tremor from Parkinson's disease. Question number 2. How will you differentiate normal pressure hydrocephalus from Parkinson's disease? Because normal pressure hydrocephalus can also present with ataxia and gait disturbances, which can be mistaken for Parkinson's disease. Now you have to differentiate these two. How will you differentiate these two from one another? In normal pressure hydrocephalus, there will be presence of dementia and urinary incontinence. Dementia and urinary incontinence. The presence of dementia and urinary incontinence and normal pressure hydrocephalus, they will differentiate it from Parkinson's disease. In normal pressure hydrocephalus, when you do CT scan, the CT scan, there will be enlarged ventricles. On CT scan, there will be enlarged ventricles. So, through these features, you will differentiate normal pressure hydrocephalus from Parkinson's disease. Question number 3. How will you differentiate Huntington disease from Parkinson's disease? While in Parkinson's disease, there is bradykinesia. So Huntington disease can be easily differentiated from Parkinson's disease when you see the clinical features. But here is the problem. There is a variant of Huntington disease called Westphal variant. So Westphal variant is a variant of Huntington disease where the chorea is substituted for akinesia and rigidity. So in Westphal variant of Huntington disease, the chorea is substituted for akinesia and rigidity, and it becomes very difficult for the doctor to actually differentiate between this Westphal variant of Huntington disease and Parkinson's disease, because in Parkinson's disease we also have this akinesia or bradykinesia and rigidity. So in this case, you will see the age of the patient. The Westphal variant has a juvenile onset, like less than 20. So the juvenile onset, you will ask the patient when did the symptoms start. So the Westphal variant of Huntington disease has juvenile onset, usually less than 20 years. Versus Parkinson's disease, which is the average age of onset for Parkinson's disease is 60. Now let's talk about what happens to gait in Parkinson's disease. There is a classical gait type in Parkinson's disease which is called shuffling gait. A shuffling gait consists of narrow base and short or small steps. The patient cannot turn sharply, and it is very difficult to start the movement and stop the movement. So this is the classical description of the shuffling gait. Narrow base with small steps, can turn sharply, and it is very difficult to start and stop the movement. Now, what happens to speech in Parkinson's disease? The speech is slow and monotonic type. So the monotonic speech is the classical one for Parkinson's disease. Now, what happens to posture? We have studied this earlier, that the posture is a flex type, stooped posture in Parkinson disease. Now let's talk about the treatment of Parkinson disease. Medicines are the mainstay of treatment for Parkinson disease. Remember that. Several surgeries are also used nowadays to treat Parkinson disease. But medical treatment is the mainstay. Remember, we used several classes of medicines. Among these, the Levodopa is the most effective treatment available for Parkinson disease. But unfortunately, none of these medicines are shown to change the course of the disease, to actually cure the disease. These all medicines we used for the treatment are only for symptomatic treatment. So the first class of drug we used for the treatment of Parkinson disease is Levodopa, which is a precursor to dopamine, because in Parkinson disease there is imbalance between the excitatory neurotransmitter and the dopamine and acetylcholine. This imbalance between dopamine and acetylcholine is the main problem which we face in Parkinson disease. So dopamine, there is decreased dopaminergic tone and increased cholinergic tone. So we have two options in the treatment of Parkinson disease. Either we will increase the dopaminergic tone or we will decrease the cholinergic tone. So we cannot give dopamine directly to the patient because dopamine cannot cross the blood-brain barrier. So it will not get into the central nervous system. So beside using dopamine, which cannot cross the blood-brain barrier, we will use Levodopa, which is a precursor to dopamine. It will get into the central nervous system and there it will convert it into dopamine. So Levodopa, which is the most effective treatment available for Parkinson disease, as a precursor to dopamine. But when given alone, 90% is converted to dopamine peripherally in the blood vessel and the GI tract without reaching to the central nervous system. So given with the dopa decarboxylase, which is actually the enzyme which converts levodopa to dopamine. So given with a dopa decarboxylase inhibitor like carbidopa and benserazide. So carbidopa, which is dopa decarboxylase inhibitor, inhibits this dopa decarboxylase enzyme. So peripheral conversion of levodopa to dopamine is prevented. Now, just we said that carbidopa-levodopa combination is the most effective medical treatment available for Parkinson disease. And it is especially effective in relieving akinesia and rigidity. Tremor response is often less satisfactory due to unknown reasons. Now, failure of akinesia rigidity to respond to levodopa at a dose equal to 1 gram per day should prompt reconsideration of the diagnosis. Now, it shows the efficiency of this drug for treating the akinesia and rigidity, because when we put a patient on levodopa, carbidopa, and the patient symptoms, especially akinesia, rigidity, fail to respond to levodopa, it should prompt reconsideration of the diagnosis. You may have done a mistake regarding making the diagnosis of this patient. The adverse effects are the side effects of levodopa is nausea, vomiting, and postural hypotension. As Parkinson disease progresses and after many years of treatment, the response to levodopa becomes unpredictable, very unpredictable. So late side effects develop. Among these late side effects, the on-off phenomena, which is called the motor fluctuations, this is worth mentioning. So when levodopa is on board, when levodopa is working well, there is symptoms free period, symptoms free time, which is called on period, on time. When the dose wears off, when the levodopa wears off, the Parkinson disease symptoms return, which is called off time. So when there is on time, the motor symptoms, they're not there. They're not there, like bradykinesia, the tremor, the rigidity. These are the motor symptoms. Motor symptoms are not there. When there is off time, motor symptoms return. So this is called motor fluctuations. And this is called on-off phenomena. And when this on-off phenomena occurs, it is very difficult to treat the patient. And it is very difficult to treat this on-off phenomena. And a question arises, how to deal with these motor fluctuations on a phenomena. We can do three things. Either use a sustained release formulation of levodopa carbidopa. So first thing you can do is use sustained release formulation of levodopa carbidopa. Sustained release formulation or adding a COMT inhibitor, catechol omethyltransferase inhibitor, the capones, adding a COMT inhibitor to the levodopa carbidopa combination. This is also shown to reduce the incidence of this on-off phenomena or to treat this on-off phenomena. The third, restricting the protein meal, restricting the protein meal of the day, restricting the protein meal of the day to night. So these three methods are used to combat with this on-off phenomena. The second late side effect is levodopa-induced dyskinesia, the abnormal movements that occur with levodopa carbidopa as the disease progresses. So this levodopa-induced dyskinesia may occur as peak dose phenomena or biphasic phenomena. What is meant by these two terms? Peak dose phenomena, biphasic phenomena. So the peak dose phenomena is when levodopa is working well, when levodopa is on board, just after a patient takes a dose of levodopa, there's the time when we say that levodopa is on board, levodopa is working well. So as the disease progresses, the dyskinesias develop as a response to levodopa. The levodopa is actually on board, but dyskinesias develop. So this is called peak dose phenomena, related to dose, peak dose phenomena. As the disease further progresses, there's time that comes where the dyskinesias occur with on time as well as when the levodopa is off the board. When the dose wears off, when the dose of levodopa wears off, there's still dyskinesias occurring. So this is called biphasic phenomena. When the dyskinesias only occurs in the on time, this is called peak dose phenomena. When it occurs on the on time as well as of the off time, this is called biphasic phenomena. And this is very difficult to treat. Now, moving on to the dopamine agonist, which is the second class of drugs used in Parkinson disease, and they include pramipexole and ropinirole. These two drugs they are using in Parkinson disease. They can be used alone as initial therapy, but most commonly they are used in combination therapy with carbidopa and levodopa. COMT inhibitors The famous capones, tolcapone, entacapone, they comprise the third class of drugs that are used in Parkinson's disease. And they're used in conjunction with levodopa, carbidopa to decrease its dose or to control the motor fluctuations. We have discussed this concept earlier in this video. To control the motor fluctuations, we add COMT inhibitor to the levodopa, carbidopa, or we can use sustained release formulation of levodopa, or we can restrict the protein meal to the night. So they actually decrease the metabolism of dopamine in the central nervous system. So they actually decrease the metabolism of dopamine in the central nervous system. This is the mechanism of action of the COMT inhibitors, tolcapone and entacapone. The anticholinergics, benztropine, trihexyphenidyl, they constitute the fourth class of drugs used in Parkinson's disease. They decrease the cholinergic tone on the basal ganglia, but they are notorious for their side effects like dry mouth, constipation, urinary retention, and blurred vision. So they are mostly avoided in elderly due to their side effects. Amantadine constitutes the fifth class of drug used in Parkinson's disease. It is basically an antiviral agent, but its short-lived effect on Parkinson's disease symptoms, specifically bradykinesia. So more commonly used for levodopa-induced dyskinesia. As we said, that levodopa-induced dyskinesias are very difficult to treat, but amantadine, is some people say that it can be used to control these dyskinesias. So the adverse effect of amantadine, this is libido reticularis. MAOB inhibitors comprise the sixth class of drugs used in Parkinson's disease, and it includes selegiline and razagiline. They inhibit monoamine oxidase to prevent breakdown of dopamine, used as combination therapy always with levodopa, carbidopa. Interestingly and unfortunately, none of these drugs, we have, as we discussed the six classes of drugs, none of these drugs is neuroprotective. None of these has shown to change the actual course of the disease. Now that we have discussed all the six classes of drugs that are being used in the treatment of Parkinson's disease, and we also know that none of these drugs is neuroprotective, none of these drugs is shown to change the course of the disease actually. These drugs are used only for the symptomatic treatment of the Parkinson's disease. But a question arises, how will you decide which drug to be used as initial therapy? For example, a patient, you diagnose the patient for having Parkinson's disease. How will you decide to start the patient on which class of drug first, and which class of drug would you use as second line therapy or first line therapy? So this is a whole different debate. So people say, experts say that first of all, you will evaluate the functional status of the patient. If the patient is able to take care of himself or herself, mean the functional status is not compromised yet, you will not go for the levodopa, carbidopa. You will go for anticholinergics. When the functional status is okay, you will go for anticholinergics. But as you know, that majority of the Parkinson's disease patients, they are older than 60, 70 even. So their age tends to be more than 70, 80. So they cannot tolerate the adverse effects of anticholinergics, like the dry mouth, constipation, urinary retention, and blurred vision. They have very difficult very difficult. They are very difficult to tolerate, especially in older population. So when the functional status is okay, if the patient is younger enough to tolerate these side effects of anticholinergics, you can start with these anticholinergics. If the patient is unable to tolerate the side effects of anticholinergics, you will go with amantadine first. But if the functional status is compromised, functional status of the patient is compromised, you will directly go for the Levodopa plus carbidopa combination. So functional status is intact, you will either use anticholinergics and amantadine regarding the age of the patient, regarding the tolerance toward the side effects of anticholinergics. If the patient is younger enough, you can use anticholinergics. If the patient is older, you can go with amantadine. If the functional status is compromised, you will go with levodopa carbidopa combination. So this was all about Parkinson disease. We tried our best to cover all the aspects of Parkinson disease, but if you have any question, comment it down.